Hey everyone, it's Josh at Prescription Fitness Physical Therapy and Sports Care, doing another video for you here today. I thought we'd talk about one of the things that I see as an issue when patients are sent home. We're going to take, for example, to stretch out big toe following a bunion surgery. Seems pretty straightforward and basic, but when we look at how people are being taught to do this and how joints actually moved, I think that's where we run into all sorts of problems. So you go ahead and you have bunion surgery, and a lot of times, for whatever reason, those patients aren't sent to physical therapy. I think that's a huge mistake. I think that especially when we look at the foot and ankle complex, it's exceedingly complex, and we really need to look at the whole foot. So if you're just looking at the big toe, you're missing a whole bunch of other things. There's all sorts of other joints that interact synergistically with the big toe that make the whole system work, and that works all the way up into the chain, up into our hip. So let's say I have my bunion surgery. I come out, I'm out of my immobilization period, and like, okay, go ahead and work your toe. Obviously, the big toe is a huge player when we're looking at adequate gait and locomotion and movement. So our big toe, it really becomes a major pivot point as we're coming over our foot every time we take a step. The big toes should be the last thing we feel come off the ground, and having adequate mobility is critical for everything in the chain to work hard. So you go to your local doctor and they say, okay, grab a hold of your toe and just crank it. So you're just taking the joint and you're just doing this. You're saying, okay, let's just take this joint and pull it back and forth. And you'll see this a lot of times too. You go to rehab and you have a frozen shoulder, and so the therapist, maybe unintentionally or intentionally, I don't know what it is, they just take the joint and they're like, here, we'll just crank the hell out of this thing going backwards, and eventually you stretch it out. Well, you're stretching out all sorts of stuff. But I think what we fail to do is recognize how a joint actually moves and why it's stiff and what we need to do with it. So when we look at all joints, so we have two sides of a joint. So we'll say this is a big toe joint. So I'll say that one side is here and the other side is here. So when the toe joint moves, it doesn't just hinge. Joints aren't a hinge. There's actually what we call a roll and a glide to a joint. So the arthrokinematics of a joint is that when a joint flexes or extends, it rolls and glides. So it has to do this. If we're just taking it here or here, we're just jamming the ends of the joints together and we're creating irritation. Sure, if you do this long enough and stretch the crap out of it, eventually it'll move better, but maybe you're irritating the joint and you're delaying the process. Remember, when we're looking at rehabilitation, what are we really doing? Are we speeding up the process? My opinion is no. I think what we do is healing occurs at its own rate. Really what we're trying to do is we're trying to make sure that healing is occurring properly, and it's occurring without delaying it. I think a lot of times we're delaying the healing process. So again, when we go to move a joint, if all we do is this, we're just jamming it together. What we should be doing is working on the glide. A good example is, imagine that I take my two hands and I saran wrap them together and I try to go to move, and I really can't. Nothing can happen. So if I take my fists and I just kind of glide them back and forth like this, eventually that saran wrap starts to move, and then I can restore that normal roll and glide to the joint, and that's what I need to do. So if I take my toe example, if I take and I just crank it up like this, I'm just pinching the joint surface together. This seems to me like a bad idea. So what we want to do is we really want to teach people to mobilize the joint, just like your therapist will. I would say all therapists are doing joint mobilizations. Chiropractics, everyone thinks chiropractors are the only ones who manipulate and mobilize. The therapists do all the time. We're trained to do this. This is what we do. We may not do high velocity thrust movements, which is really just a certain grade of a joint mobilization. But if I'm just taking my toe and I'm just gliding it, I kind of pull it, and if I'm working on, again, so here's my foot, if I'm working on extension, what I want to do is I just want to take the toe and I just want to glide it upward, because I'm helping to restore that normal glide and the roll of the joint. So there's our little tip for the day on joints and how they move. It's a little bit more complex when we look at it, let's say a ball and socket joint. The patterns of movements are a little bit different, and how we mobilize and move that joint is going to be a little bit different. But joint mobilizations are critical to getting all joints to move. Anytime we take a structure and we immobilize it, there's some statistic, and I probably get this one wrong, but I feel like the statistic somewhere is around the range of atrophy occurs within 3 days and occurs at a rate of something like 0.3 or 0.5%. a day. So that's a ton. The joints get stiff. They're not moving. We need to move them. So if we're going to move a joint, let's move it properly. So don't just take a joint and crank it. That's a bad idea. We need to understand how joints move. Your physical therapist is certainly well positioned to educate you on how to do this properly. Mobilize the joint at home, and you'll find that you have a much more successful rehabilitation.